And we are asking Dr. Sirakov to come and to present Demystifying the Complication.
Thanks for the invitation. Although I'm happy to be here at the podium, I'm quite sad because I will do my best to summarize a very horrible complication
Is Simone, Dr. Pesquillo here? Or he's with... He was in the angel room. Okay, so he will be the next one. Or probably last. Okay, let's go ahead.
Sure. Where was I? I'm going to show you a very horrible complication that we had quite recently. It's in regards of a patient, 46 years old, that had a previous history of SAH in another hospital. The assumed ruptured aneurysm was caught uneventfully. She was screened to have another contralateral ICA aneurysm, totally asymptomatic by this point. And during the follow-up conducted in our department, we noted slight residual of the aneurysm that was meant to be ruptured. Apart from this, there were no medical background. The patient was in a perfect condition to the point of the follow-up. So I had discussion with the patient and basically told her that this recanalization or probably the other aneurysm should be treated at some point. She agreed to be treated in our department, possibly with flow diverter stent or a secured coiling of the contralateral aneurysm. This is the MRIs that we conducted, and I try to upload them here just to emphasize on the fact that the patient was perfectly fine before the treatment. This is the flare imaging. As you can see, the gradient sequences demonstrating no presence of any vascular changes or any underlying vascular conditions like cavernomas or CAAs or whatsoever. This is the time-of-flight imaging that we actually used to acknowledge the presence of recanalization, and we saw the contralateral a-ruptured aneurysm on the left side. These are the virtual reconstructions, and you can see the morphology appearance of the aneurysms. So we proceed with the treatment of the patient. By protocol, we were expecting to flow divert the aneurysm, so we presumably premedicated the patient with double antiplatelets, as we do every time with double antiplatelets, 10 milligrams of prasugrel, aspirin 100 milligrams. The procedure went uneventful. This was the working projection that we used to coil the contralateral IC aneurysm. Uneventful coiling, a little bit toughly to form the stable basket inside. Nothing in particular, nothing to change our mind here. We didn't observe any contrast extravasation to the point of the final angiography, and we placed the patient as per protocol inside the ICU. She stayed there for 12 hours without any clinical consequences. She was dropped to the neurosurgical departments, and suddenly 24 hours later, she was reported to have an onset of a thunderclap headache accompanied by vomiting, dizziness, and drop of consciousness. This was pretty alarming. We sent her straight to the CT scan, where she was, at the point of the CT, she was unconscious, and we observed the following changes: contralateral presence of SAH, intraparenchymal changes in the occipital lobe, and a very tiny but present subdural hematoma. So we were really anxious. What wrong? We were really scared. How the hell these changes happened to this patient without any trauma or something like that? We double-checked the videos. There was no trauma. There were no bruises on the head of the patient. We stopped the DAPT to make sure that, because we didn't need it actually, right after the procedure, so there were at least 24 hours of the period without any platelets being added to the patient. We only applied one prophylactic dose of factor 10AX inhibitor, but that's per protocol for every patient that stays in our department. There was a clinical and neurological deterioration of the patient, so the neurosurgery team decided to proceed with evacuation of the subdural hematoma because they presumed that might be the case of a possible herniation. They evacuated the hematoma, and 24 hours later, or 48 hours after the initial procedure, the patient experienced a new set of complications, that extensive bleeding that we see inside the ventricle, expansion of the occipital hematoma, and the contralateral intraparenchymal hematoma. The WAP findings were kind of concerning as well. We saw droppage of the hemoglobin and thrombocytopenia and leukocytosis, the extensive bleeding from literally everywhere. So we were really in a hurry. Also some weird changes to the skin, like the broad discolorization and small tiny petechias across the body. We called the hematology doctors, the GI, the cardiology, and the WAP doctors to make sure that we're not missing something that is present and obvious. We tried to rule out Dick syndrome, and then all the coagulation factors were absolutely normal to the point of the second complication. The hematology doctors actually requested a more deep and more profound examination of the coagulational cascade, and everything appeared to be normal because we were suspecting that this might be heparin-induced thrombocytopenia. The GI doctors ruled any acute failure of the liver, and also they pointed out the presence of a psoriatic hematoma that might be related to the procedure itself. We took some samples from the liquor, from the drainage, and there were no pathologies found besides for the erythrocytrachea. This is the CT scan that we observed, and of course the following cranial CT scan that was done after the EVT placement and the decompression of the edematous brain. We kept the patient under sedation, and at some point we decided to cease the sedation just to double check what's the neurological condition of and the status of the patient. She demonstrated slight improvement, somewhere in between of 11 points of Glasgow Coma Scale. Still some hemiparesis on the right side, stable hemodynamics. We proceeded with many control of the vital functions and correction of the sodium levels, of course. This is the last CT scan that we had, diffuse ischemic changes accompanied with intraperitoneal hematomas. Furthermore, we invited the genetic doctors, another rheumatological consultation and another hematological consultation. So we made sure that there were no inherited coagulational disorders or uncommon pathogens that we were actually missing. The rheumatology doctors ruled out any systemic diseases or anything related to the common changes in the antiphospholipid syndrome. Of course, the recommended thromboelastography was within the normal range. Every blood cell was actually working properly to that point. New set of complication, of course, occurred 7 days later. We don't know why, but another round of bleeding. You can see the massive expansion of the edemic changes in the left hemisphere. So, of course, she went for another catch-up of neurosurgical intervention. This is the latest CT scan that we have 8 days post-treatment, post-embolization of the aneurysm. We'll go back just to double-check the CT scan, sorry. A slight improvement, actually, but the changes are drastic. We stopped the sedation to continuously monitor on the neurological condition of the patient. There were no signs of improvement, unfortunately. The vital signs remain normal. The WAP results returned to normal range. However, 66 days later, the patient died due to organ failure and systemic inflammatory response syndrome. And to this day, we requested an autopsy as well as the family, which is a common sense, of course. We had tons of different theories whether we might have dislodged any sort of like hydrophilic material distally to the parenchyma of the brain. Unfortunately, the autopsy failed to document any presence of foreign body reaction or foreign body materials within the cerebrum at all. There was no presence of cerebral ischemia, only vast zone cerebral infection, only vast zones of ischemia, necrosis, and hemorrhage. We were like working around. We had like tons of food for thought, and then we were thinking about the Sneddon syndrome as well. However, the examinations of the vasculature didn't confirm the presence of any arteriopathy or something like that. So we still don't know what happened with this patient. And the idea of this presentation is basically a call for help. If you guys have any idea, we were we'll be happy to hear you out. This patient was actually commented with Professor Kusser, and he had a very interesting idea that silent emboli during the procedure might be related to the consequences we've observed. But I have a question too, why this is the only complication like this that we see in our practice, despite the fact we bypassed over 3,000 cases. Yeah. It does make sense to be bilaterally because we did a left injection, we did posterior injection, we did contralateral injection.
A little bit more data about the anti-aggregation test you did and the dose of the paracetamol aspirin. And then we will accumulate the discussion.
Professor Bocardo? Sure. Please join us because you are moderator in this session and we kind of...
Most probably some platelet dysfunction. This is the most
Sure.
logic.
Okay.
Yeah, probably.
Thromboelastography, everything turned out to be within the normal range. We felt the same. We felt the same. Probably the platelets were not working properly. Why do we have the diffuse interruptions in the coagulational cascade? All the factors, everything appeared to be normal, but why? I didn't actually hear you, Professor. I'm really sorry.
Just start the discussion again. What is the dose, maximum dose you gave the paracetamol and aspirin?
So,
And what was if you did the anti-aggregometric test and the resistance test for that? Did you do it or not?
No. The answer is no. The regimen that we assigned, I personally assigned to this patient, was 10 milligrams of prasugrel 3 days before the treatment, on the early morning, and 100 milligrams of aspirin later in the evening. We did no testing. We usually, per protocol, we used to do testing when it comes to prasugrel and copridogrel activity, specifically with Verify Now. But in our population, after, let's say, we've accumulated 200-ish patients, we've seen no resistance to prasugrel, but quite the opposite. The numbers in the platelet reactivity units were really low, meaning that it's really an aggressive drug. The lady was with the average body mass index, and that's why I stick to 10 milligrams, and I didn't half the dose to 5 milligrams. So everything was, in my mind, everything was per protocol. This is how we do it. This is how we do it in our department.
Yeah, I understand. That is a terrible complication. No, yeah,
Horrible.
that is obvious. But we should know that whatever we do properly, either by coiling or stenting, we are sending some slight emboli to the brain.
Yeah.
And for the expert CT or any CT after the embolization, you cannot see that. The problem is anti-aggregation and thrombocyte function here, because you had vaginal and other bleeding afterwards, and then 7 days later re-bleeding in the brain. In the parenchymal one. What is interesting for me, when you check your first CT, there is an intracerebral cortical and subcortical hematoma.
Yes.
And then the subdural one. Exactly. And that is clearly showing that the thrombocytes are kind of a non-functioning. And then it is contraindicated that prasugrel is given to the acute ischemic situation. And we can create our acute ischemic situation. Another question for you, during the embolization, you should mention about that. I think you didn't. Did you have a parenteral occlusion transiently?
I performed the procedure. It was like 15 minutes of coiling, no complication. She wakes up, okay. She goes for intensive unit care for 24 hours per protocol, no complaints. She was removed from intensive unit care, 6 or 8 hours inside the room with 2 additional patients, no complaining. And then she called her relatives to say she had acute onset. So we also asked the other 2 ladies in the room, did she had bang her head or something else? Nothing.
Yeah, because having
and she
SAH,
has no
no
visual
bruises, no
symptoms
nothing.
of
No bruises on the skin.
of
Everything was
trauma.
intact.
We have a lot of, okay, you can, yeah. We have a good friendship.
Probably we have to interrupt this discussion because obviously we are not going to find the source of the complication, the reason. Most probably it's a systemic because there is bleeding from everywhere. It's most logic to have some disturbance of the platelet function and so on, but obviously we cannot find any reason. Like you didn't.
We found the same, we just didn't find.
Yeah, it's okay. Thank you. Thank you. It's a really very complicated case. And let's go, let's proceed. In fact, Simone went to take his, Simone is already here. So, great. Simone, it's your turn. Yes. You have the floor, and I see that you have also the laptop.